Hi everyone, this is Medicine in Minutes. Welcome back to my channel. And today I'm going to discuss about the importance of hypoxia in chronic carbon dioxide retained patients. So we know there are various respiratory diseases such as COPD, especially the chronic bronchitis, interstitial lung diseases such as non-specific interstitial pneumonia, usual interstitial pneumonia, and bronchiectasis and various other respiratory diseases can result in chronic carbon dioxide retention. So we know our respiratory drive is maintained by two most important things. One is hypoxia, other one is hypercapnia. Hypoxia means the low oxygen level in the tissue, and hypercapnia means the high carbon dioxide level in the tissue. So when there is hypoxia and hypercapnia, our respiratory centers will be stimulated and we'll end up in hyperventilation so that we can get more oxygen inside the lungs and we can put out more carbon dioxide outside the lungs. So that's the usual mechanism. But those patients who are having chronic carbon dioxide retention, so their situation is different. So usually when there is high amount of carbon dioxide level in the body, those carbon dioxide will be bound to the carbon dioxide receptors which are situated centrally in the medulla oblongata and peripherally in the carotid and aortic bodies. So they will be saturated. So which means when there is high amount of carbon dioxide for a prolonged time, the carbon dioxide receptors will be saturated. So when a receptor is saturated for a prolonged time, that receptor will be undergoing downregulation. So what is downregulation? The downregulation means when the receptors are bound with the agents for a prolonged time, those receptors will be engulfed by the cells so that the receptors will no more available to bind with the agents. So that is known as downregulation. So when there is carbon dioxide retention for a prolonged time, those carbon dioxide receptors will be undergoing downregulation, which means in those patients who are having chronic carbon dioxide retention, the number of carbon dioxide receptors will be less and less sensitive for the carbon dioxide. So with the time, in those patients, the hypercapnic response for the respiration will be diminished. We can say they will lose the respiratory drive for the hypercapnic level. So high carbon dioxide level will no more drive the respiration in those patients. So what will happen? Our respiratory centers now will be only responding for hypoxic level, not for the carbon dioxide retention. So now our respiratory centers are only sensitive for hypoxia, not by the hypercapnia. So what is the only source of respiratory drive in our body right now is hypoxia. So we call it hypoxic drive. So those patients, when they come to you and if you supply more oxygen to those patients, that hypoxic status will be abolished. So the only drive that they have for the respiration will be abolished and they will be ended up in type 2 respiratory failure and eventually respiratory arrest. So that's why in those patients we have to make sure that we supply the controlled oxygen, and usual target is 88 to 92%, which will be enough for them to keep the respiratory drive. So always remember, when you give oxygen, don't think it's always a medicine, but it can be poison to those carbon dioxide retained patients, and that can eventually kill them. So always remember, oxygen can save the patient. At the same time, oxygen can kill some patients. Thank you.